so much. It's a pleasure to be here. I'm sorry to be a health economist standing between you and your morning tea, because you know we health economists come loaded with graphs and numbers. So I don't make excuses for it, but I apologize for it. So what's the, where can I see the slides? I can't see the slides, I have to look them up here. So the projections suggest that Australian life expectancy will fall from 5th to 10th by 2014. This is not my projection. And that life expectancy will rise more slowly. And so we've been asked, commissioned by the Health and Wellbeing Queensland to try to reproduce some of Jay's work that he just spoke about that came out in the New England Journal of Medicine. Unfortunately, the data we have for Queensland is not as rich, but I'm going to walk you through what we did and how we got the numbers of around up to 4 years reduction in life expectancy compared to the kind of linear projections that ABS makes. And that's effectively reversing improvements in life expectancy of 2 decades. So hence, you know, theoretically, a child born to a 20-year-old is living a shorter life than when their parent was born. So I'm going to start with a bit of background and why at least I have an interest in producing figures like this. This is not a figure that is going to change the trajectory of what's happening. It's really a figure that helps to communicate to the community how big a problem we have. And that's really, I think Jay has mentioned that as well. It's about how we communicate the epidemic of obesity we have to ordinary Australians. That's the hardest job. So as a health economist, when we think about investing money in prevention, an example is cancer screening, we're often asking ourselves, what do we have to pay versus what will the reward be? We're having to weigh up the costs and benefits. Now, in obesity prevention, we're in a very odd situation. What is that situation? We have a plethora of programs and interventions that in health economics we call dominant programs. What are these programs? These are programs that save money and improve health. In fact, if you think of a sugar tax, they make money and they improve health. So then we're thinking to ourselves, at least I as an economist, so what you're telling me is I've got a whole suite of programs I can lay before the bloke who used to be health minister, and he won't have to go and raise taxes. He can say, yes, 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 I'm going to buy those programs because it doesn't cost me any money and it improves my health. Why do we not do those things? It's because sometimes those policies actually do hurt people. They don't hurt communities, they hurt industry. And so what we need to do with the kinds of facts that I'm laying before you today on life expectancy is take those messages and take them and produce from them what I call a social license. A social license for community action, a social license for leadership action, a social license for policy change, a social license for sugar tax. Because what we've seen, and this is a really awesome paper done by a couple of political economists, they went through and tried to understand why it is that in Australia, when we know the stark facts, when we know the policies that we need, we don't do anything about it. And they essentially said the challenge is we don't have a single kind of policy leadership. We've solved that in Queensland. That's why I think in Queensland you can be a national leader. We do now have a single policy voice. The other thing they said is that there is what they call a counter-framing of this discussion. So what are the kinds of counter-framing measures they were talking about? They were saying that when you start discussing anti-obesity policies and programs, people say, oh, it's the slippery slope, it's the nanny state, it's that the economic case is not compelling, the effectiveness evidence is not there. That it's really about what people put into their mouths. How many times have you heard that? It's just about what people, if they can just, and this I quote, a candidate for Queensland, if they can just shut their gobs, they'll be okay. That's how the framing makes it really hard for us to move forward with policies. So what Health and Wellbeing Queensland asked us to do is 3 phases of a project. This is just the phase 1. To ask in a simple, kind of single metric, what is it that we expect to happen to life expectancy for Queenslanders born in 2023 if we do nothing and the projected obesity continues? So it's kind of what is at stake as part of that single piece of information to build the social license. So at the moment, ABS projections project that males will live about 80 and females will live to about 85. However, when we do these life expectancy calculations, we tend to use the existing mortality rates by age that is observed historically. This is fine, except for times of pandemics, we're probably wrong. At least in Australia, we're right, but in other countries, we might be wrong. In times of war, we know we're always wrong. But in general, if we have a steady state of mortality by age, by gender, we're probably right. But we don't have a steady state. And so what we did in this work is we took a sort of a conservative assumption, what we call a realistic assumption, and said, actually, what we have is a cohort effect. That is, every generation born in Queensland, when we go and see them in adulthood, we see that they are slightly more obese than the previous generation at the same age. So now if I'm going to ask myself, what's the risk, mortality risk, of a child born in 2023 when they become 35? How can I use today's 35-year-old's mortality risk to project that? When I know that every time I measure obesity in a 35-year-old, for every subsequent cohort, I'm seeing the rates are higher and higher. That just doesn't make sense, right? Why would we do that? And that's what we do. So, as I said, and this is all the data we have. So I apologize that the project, we had to squeeze a lot of blood out of a very dry mode of data. So we don't have a lot of cohort observations and age-specific observations for Queensland, but we did what we could. So this is just to highlight, this is data I'm seeing for different years of observing, so different cohorts observed at the same age. I'm seeing that obesity rates are higher. I'm also seeing a second effect, right? As people age, at least from through to the prime age groups, their obesity rates are going up. So I've got a cohort effect, and I've got an aging effect. So what I need to find is a kind of cohort-independent aging effect. So I start with a child born in 23, and I project for them what their age-specific obesity rates are going to be over their lifetime using historical information about this kind of cohort-independent aging effect. So I'm doing a mixture of looking at the longitudinal data, looking at the cross-sectional data, and trying to do some adjustments. So from this, we get a kind of an estimate of a conservative and sort of realistic obesity trajectories and calculate BMI. From that BMI, We then looked to a paper of 900,000 adults that was published in the Lancet in 2009 that gives us hazard rates by age, by gender. So now I've projected my obesity rates for my 2023 cohort. So I'm seeing them going up and up. And then for every age year, I'm going to multiply the risk of mortality by the projected obesity rates. Not so easy because we actually don't have relative risks in the population, so I had to extract that from the ABS data. But anywho, that's what we did. So basically, we applied these relative hazard rates to our projected mortality, projected obesity rates. And we came up sort of with a very wide interval. As I told you, we're squeezing a lot of information from really not a very rich data set. But essentially, this does project exactly what Jay found in the US, a reduction in life expectancy. And a four-year reduction is around, if you look at mortality rate, life expectancy historically for Queensland, 4-year drop is around 2 decades of improvements. Now, when we did the same thing for the First Nation people, we find a larger effect for 2 reasons. One is their baseline obesity rates are higher. 2 is that baseline mortality rates are higher at every age. So remember that hazard rate is really about what it does to your relative risk of death, and if you have a higher baseline rate, it's going to exacerbate it. So really, the kind of realistic estimate says that we are going to increase the disparity in life expectancy between First Nation peoples by up to 50%. And this is kind of just a picture of when the impacts happen. And of course, we've got caveats. We know that, for example, cancer survival rates are improving. We know technology is improving in cancer cures. So we might see that these are offsetting effects. So a lot of the mortality, the life expectancy improvements in the last 4 decades were smoking, anti-smoking program, safer cars and traffic improvements, improvements in men surviving heart disease. So those are kind of few big things that happen that improved life expectancy. There could be things like that happen to our babies that improve their life expectancy. But at the moment, the picture isn't looking all that good. So what are the policy implications of this? So we kind of looked at what we would need to do in order for that linear projection of ABS to be true. What do we need to happen for a 2023 baby? Well, they need to exit adolescence. They need to exit childhood into adulthood at roughly half the obesity rates to what we project they're exiting today. And what does that look like? It looks like they need to go through childhood like a 1970 to 82 cohort. That's basically it. If we can expose them to the same environment that most of you grew up in, we will see them exiting into adulthood at about the right levels of, of course, no obesity is good, but if we can get there, that'll be a good thing. So I really like this picture because it's by Boyd Swinburne and colleagues. It tells us the kind of scope of how we have to move forward on obesity. And as a health economist and really a policy person, I am really interested in the stuff that happens on the left-hand side. So the left-hand side is population-based policy and regulatory interventions that really make a difference to the environment in which people are growing up. So I am very keen that this work not be converted into personal responsibility narratives. I was on ABC this morning. They probably didn't quote me. I said, look, for anyone out there listening to this story, I don't want you to start getting your kids to exercise. I don't want your kids to start eating healthy. I want you to pick up the phone, call your school, call your MP, call your minister, and ask them, what are you doing about sugar in our drinks? Because it's got to be a social license for policy change that we've got to demand. Personal responsibility is not going to get us there. That's my feeling. I mean, obviously, I have no evidence for that, but that's my theory. I always caveat what I say. Suddenly I realize something I'm rhetorical, and then I think, oh gosh, I better say I have no evidence for that particular statement. But anyway, so this is kind of it's on the left that is the hard work, hard grunt to get to the left. And what is it? It is basically the obesogenic environment that we're giving parents and children today. It makes parenting just much harder. So I think the message is it's just hard to be a parent today and get your kid, become an adult at a healthy weight. It's not your fault. We're making it hard for you. If we made crack cocaine available and said, parents, just be careful your kids don't take it, right? That would be a huge revolution. So why aren't we saying it's not about the parents, it's about the regulations? So when we go back to 1971, what's the difference? There was no marketing that targets children. Children don't understand marketing. They don't. They can't distinguish between marketing messages and what their school teacher and their parents says. There is fast food was more expensive, less common, nutrient content of food was not so degraded, there were active modes of transport. And so this is not my nightmare scenario. Let me tell you what my nightmare scenario is. In 2020, there was a paper that came out in PLOS Medicine, written by people not dissimilar to me, a couple of professors at University of Sydney, that showed that restricting trans fatty acids in food in Australia would save countless lives and reduce and improve health and decrease costs. So it was a no-brainer. 2020 came out. They did a much more careful study than this I could do with the data I have. They published it in a top journal. They had interviews on ABC exactly like me. They probably presented it to good folks like you. What happened? What happened? 2023. Tell me what's happened to trans fatty acids in Australia? Nothing. Nothing. So I will come here, I will give you these facts and figures, I will be on interview, I will come back in 3 years, and we would not have moved the policy and the regulation, which is what we need to do. So why was that not converted into policy and regulation? And that's not for me to answer, that's for the great people in this room to answer, that's for Health and Wellbeing Queensland to answer, but I really hope that I'll come back in 2026, and we will see some change in policy. Thank you.
Professor Vaithyanathan, thank you so much.